The session today is again on diabetes, this time diabetes and infection, and Nick Oliver will chair that. The idea of these sessions is to bring people from different parts of the college together who wouldn't normally meet, so they're not meant to be like department sessions. And usually we do have a nice mixture of people. The next session that we're going to have, which will be in June, will be on respiratory disease, and we'll have people from public health, from engineering, and from medicine to add to the mix. It'll be quite a diverse group. I think that one thing that I would like to say is that we are already starting to think a little bit more about the next year's sessions. As I say, the idea is to put sessions together that will be multidisciplinary and not simply people who meet the whole time to discuss the same old things, so that we can get something maybe a little bit more innovative going within the college. If you have some bright ideas, and I'm sure there are lots of people here who do have bright ideas for putting a session together, we'd really like to hear from you. So catch me. There will be tea after this session out there where people can socialise and discuss what they've heard today. But get hold of me and tell me if you would like to put something on. We're always looking for new ideas and innovative ideas. So with that, over to you, Nick, and look forward to an interesting session.
Thank you. I'm sure it will be. So this is part two of two sessions really, discussing the interaction between non-communicable and communicable disease, and in particular looking at the global landscape for diabetes, glucose intolerance, diabetes prevention, and how that interacts with risk for infections worldwide. We've got three talks today, first from Shivani Misra, then John Tregoning, then me at the end talking about diabetes prevention. Please make it as interactive as possible. Put your hand up. This is supposed to be a debate and discussions and a forum environment. So in any way you'd like to take the discussion, please let us know. But I think each talk is about 20 minutes. So if we start with Shivani, and then perhaps we can have a quick discussion after that, and then at the end we'll have a discussion and bring together all three of the talks. So it's a pleasure to introduce Shivani Misra, who's one of the research fellows in the clinical diabetes department, and she can tell you about her study and her clinical interests around multi-ethnic diabetes and risks for diabetes in different ethnicities.
Thank you very much, Nick. Great, so hi everyone. As Nick said, my name is Shivani Misra. I'm a clinical research fellow in the Department of Diabetes and Metabolism. I'm going to talk to you today about young-onset diabetes phenotypes around the world. Now, actually, I can talk about diabetes around the world, but actually we're all based in London, and most of what I'm going to tell you today has been derived from patients that I've seen in the diabetes clinics at Charing Cross, Hammersmith and St Mary's, which obviously serve a very diverse local multi-ethnic population. So we don't have to look too far to see the implications of diabetes phenotypes around the world. Now, I know you're not all diabetologists, but this is a case history just to sort of orientate you. Imagine we've got a 25-year-old man and he's been feeling tired and a bit thirsty. He goes to see his GP and the blood glucose is significantly elevated at 18, which is diagnostic of diabetes. And as a physician or a general practitioner, you have to answer the question, what type of diabetes does he have? Now, why is that important? If he's got type 1 diabetes, we're going to be doing certain things. We're going to be prescribing insulin injections, talking to him about insulin pump therapy. We're going to be giving him a glucose meter so that he can go home and check his blood glucose. We're going to give him type 1 diabetes specific education, which includes how to prevent life-threatening complications such as ketoacidosis. He's going to learn to carbohydrate count so that he can dose appropriate insulin for his meals. And it might even affect his employment. That's very different to what's going to happen if he has type 2 diabetes. I don't need to go into the different drugs, but most of the starting drugs for type 2 diabetes are tablets. He wouldn't get a glucometer to measure his glucoses because that's not part of national guidance. And if he lives in an area that has access to type 2 diabetes specific education programs like Desmond, he might have access to it, but the uptake and dissemination of that program is not great. But could he have something else? And if he has another type of diabetes, and there are lots of other types of diabetes, he might need insulin, he might need tablets, and in fact, there are some types of diabetes that don't need any treatment at all. Getting the subtype of diabetes wrong has a lot of implications. Someone with type 2 diabetes that is misdiagnosed as having type 1 diabetes, well, you could call that quite a significant inconvenience because they end up getting insulin injections. That's a life-changing intervention for them. They didn't actually need it. The opposite scenario is even worse. Someone with type 1 diabetes that doesn't get insulin is at risk of that life-threatening complication that I mentioned, ketoacidosis. Now, you might think this doesn't happen. It really happens. We see it all the time in our clinics. People have been diagnosed as having type 2 out in the community. They come to the specialist service. Actually, they've got type 1 and they need insulin. Most of the time, we're lucky enough to pick it up before they enter that life-threatening complication. Sometimes we're not. If they've got a different type of diabetes, maybe they won't get the optimal treatment, the optimal drug choice that works best for them. But there's other considerations globally, aren't there, of getting the diagnosis wrong. The identification of type 1 diabetes in developing countries is really critical. It will affect people's access to insulin, or whether they need insulin, the testing kits, the needles, syringes, the specialist support. We take those things for granted over here, but in some of the countries, as you can see in this table here, from a study in 2010, there is a huge disparity in the availability of equipment that you need for type 1 diabetes. And of course, if someone in a developing country has developing type 1 diabetes and is not given insulin, there's a huge risk of morbidity and, in most cases, mortality from that. So what's going on here? Why do we have this problem with subtype recognition? Well, I've tried to summarise it in this diagram. Type 1 diabetes is conventionally thought to occur in younger people, and type 2 diabetes in older people. If we looked at people's BMIs, they would be lean in the type 1 diabetes category, but overweight in the type 2 diabetes category. Type 1 diabetes is associated with ketoacidosis, but type 2 isn't. And if we measured antibodies, remembering that type 1 diabetes is an autoimmune process, if we measured those antibodies, we would expect them to be positive in type 1, but negative in type 2 diabetes. Well, I've told you all of this, but now put it out your mind, because it's completely wrong. And the reason it's wrong is because there's lots of exceptions. We know that type 1 diabetes can occur in adulthood. Some of the larger studies have shown that 20 to 30% of type 1 diabetes presents after the age of 20. So age at diagnosis is really insensitive. We know that type 2 diabetes can occur at younger age. There is a burgeoning proportion of adolescents, we have them in our clinic, who have type 2 diabetes. The concept that type 1 diabetes patients go from producing lots of insulin to producing zero insulin is also completely wrong. A lot of people with type 1 diabetes manage to maintain a little bit of insulin secretion, albeit not enough to maintain normal blood sugars. Type 2 diabetes is not a condition of just the obese. There are plenty of people who are obese who do not get type 2 diabetes, and in certain ethnic groups, you don't even have to be in the overweight category and you can still develop type 2 diabetes. Although the antibodies are a really good discriminator if they're positive, there are a proportion of people who are antibody negative at diagnosis, and this occurs particularly in certain ethnic groups, and I'll come back to that. And finally, the idea that if you have DKA or ketoacidosis at presentation, it's got to be type 1. That's also wrong, because there's a new sort of condition that we have increasing recognition of called ketosis-prone type 2 diabetes, and these are people with type 2 diabetes that present in ketoacidosis. So all of the things that are written in the textbooks that we can go and grab from the library no longer help us. And actually, I would say that the phenotypes of type 1 and type 2, as our population has changed and as our understanding has developed, mean that the phenotypes or the clinical presentation completely overlap. And these criteria of age, a diagnosis, BMI, and whether or not there's ketoacidosis do not help us. And actually, these other types of diabetes are also really important to recognise. So, all of this is a huge problem in everyone, but it's a particular problem in people with younger onset diabetes, which is where my research focuses, and also in people from ethnic minorities. And what are these other types of diabetes? Well, there's loads, there's lots. I could spend ages talking about them, but to keep it simple, there are genetic forms, most commonly maturity onset diabetes of the young. That's a monogenic form of diabetes that people inherit from their parents. It accounts for between 1 and 4% of diabetes cases as a whole. It has a different treatment to type 1 and type 2, so there's real benefit in trying to diagnose it. And there's also these intermediate forms of diabetes. I've mentioned ketosis-prone type 2, but also latent autoimmune diabetes of adulthood, which is a very slow-burning type 1 diabetes that presents later in life. So how can we improve classification if the clinical criteria are insensitive? Well, I'm going to focus mostly on the specialist biochemistry tests that are mentioned in point 3. Now, there are 2 real specialised tests that we would do in clinic. I've mentioned the antibodies already, and I've put the names there: GAD65, IA2, zinc transporter, and insulin. Those are the 4 antibodies that we can currently measure. And those are proteins that are found in the beta cells. The beta cells of the pancreas make insulin. And for reasons we don't understand, people with type 1 diabetes, if you measure in their serum antibodies, you can find antibodies to these specific proteins. No one really knows if that's the cause of the damage to the beta cells or if it's an effect, but they're usually there. The caveats are, as I've mentioned, they're not always positive in type 1 diabetes. And although they're positive in about 90% of white European people at diagnosis, the positivity in other ethnic groups appears reduced. And this might be because other ethnic groups form different antibodies and we just don't know what they are. All of this data has been derived and studied in Northern European populations. So whilst the presence of pancreatic autoantibodies has a very high positive predictive value, so it's good if it's positive, it means it's type 1. If it's negative, you cannot be reassured that it's not type 1 diabetes. The other thing that we can measure is C-peptide. That's a protein. It's a cleavage product of pancreatic insulin. So when the pancreas makes insulin, it makes something called proinsulin, and then that gets chopped in half. And half of it is insulin, the bioactive insulin, and half of it is C-peptide. And we don't think C-peptide does anything, but it's great for us because we can measure it, and that's how we differentiate between insulin that is made from the pancreas and insulin that is injected exogenously. But the problem with C-peptide is that no normal ranges have been defined. I could not tell you what a normal range for a C-peptide level is in any healthy individual, let alone anyone with type 1 or with type 2 diabetes. In fact, in the last few years, we've started to look at C-peptide levels, and we've seen a huge spread in people with type 1, type 2, MODY, virtually every type. And if people have tried to develop cut-offs, those are cut-offs in a very particular ethnic group and particular population, and they might not apply to other ethnic groups. It might be that South Asians have slightly higher C-peptides than African Caribbeans. We simply don't know. So we have these specialist tests, and they are useful, and they do help us, but they're not independently discriminatory. The other thing to mention, of course, is that we're really lucky. We work in a tertiary centre. We have these assays on site. If I want to get a GAD65 level, I could get it within a few days. If I wanted a C-peptide, I could rush up to the lab and get it measured. C-peptide's quite unstable. It needs to be taken on ice and centrifuged within half an hour. Now, if you're in a developing country and you suspect that someone has type 1 diabetes, these kind of tests are simply not feasible and you won't have access to them. So we need to think about how we can support differentiation of diabetes that we find hard enough over here in other developing areas. Now, back in 2011, before I started my PhD, I was in the clinic and I asked the question, how does ethnicity impact on diabetes subtype and phenotype? And I did a literature search at that point, and the answer was we don't know. We simply don't know. There is a huge knowledge gap as to the effects of ethnicity on the characteristics of all the types of diabetes that I mentioned. And this is what really led us to set up the My Diabetes study, which I'll talk about now briefly. So the My Diabetes study is a UK multi-centre cross-sectional study of young-onset diabetes, and I recruit people who were diagnosed with any type of diabetes before the age of 30. So really focusing on that young onset group where the diagnostic conundrum lies. And we're recruiting from 3 matched groups: White European, South Asian and African Caribbean. And it's a cross-sectional study, so they come in for a single visit and we phenotype them by looking at those specialised tests, but also taking a DNA sample on everyone and looking at their genetic background, and also filling in a questionnaire about their diabetes history. The study was set up to actually look for monogenic diabetes, which is also hugely underdiagnosed in non-white ethnic groups, and I'll come on to that, but it offers us a great opportunity to just look at the phenotype of type 1 and straightforward type 2 diabetes across the ethnic groups. That study is in progress, and we're about a third of the way through recruiting, so we'll have some results hopefully by next year. But when I went back to this question of how ethnicity impacts on diabetes phenotype, I sort of broke it down, and I think there's obviously an effect on the recognition of subtype, but there's also an effect on the fact that types of diabetes may be slightly variable in their presentation. So let's talk about how ethnicity might affect the recognition of different subtypes. Let's look at straightforward type 1 versus type 2 diabetes. Now, NICE, we all follow NICE guidelines over here, and NICE guidance on type 1 diabetes in adults tells us to consider the diagnosis of type 1 in people who are diagnosed before the age of 50, so that's quite broad, and have a body mass index below 25. Now, here's a graph taken from Naveed Sattar's paper in The Lancet this year, and this is a graph of women, white European, Pakistani or Indian women in the UK, and it shows the point at which there's a 5% diabetes prevalence by their BMI. And what you can see is that when Pakistani and Indian women have a 5% prevalence of type 2 diabetes, their BMI is somewhere between 21.5 and 22.5. The normal range for BMI over here is between 20 and 25, and now the South Asian BMI cutoffs have been refined, so between 20 and 23, but still that's completely normal by the BMI standard. And for the same prevalence of diabetes, the white European takeoff is at 30. What a big disparity we have there between BMI. So if I've got a patient in front of me and their BMI is 22, I can't really say for sure that they've got type 1. They could have type 2. In fact, I decided to look at this in our clinic. So I collated all of the data from our Imperial diabetes clinics, and I looked at whether the consultant who had seen the patient had assigned them as a diagnosis of type 1, which is the blue lines and dots, or type 2, which is green. And what you can see in the people who were Caucasian, there is a very nice statistically significant difference between the median BMIs of people with type 1 and type 2 diabetes. There's a significant difference in the African Caribbean group, although the whiskers obviously overlap. And in the South Asian group, there is a complete overlap, as we would expect. But you could say, well, maybe the clinicians in the clinic, maybe we're not very good at separating the types of diabetes, and actually we got it wrong, and half of the type 1s actually have type 2 and vice versa. So how can we look at this more objectively? Well, some data that I'm just writing up at the moment is an early analysis of the My Diabetes cohort. So the great thing about the My Diabetes study is we don't rely on what the consultant said. We actually measure C-peptide and we measure antibodies, and we make objective decisions about whether people have type 1 or type 2 diabetes. But you can see again that in the South Asian group, even using this objective assignment, which no one does and is not recommended, the South Asian group has completely similar BMIs between type 1 and type 2, but there's more of a separation in the white European and African Caribbean group. So NICE guidance tells us to use BMI to think about who has type 1 diabetes, and actually it's completely insensitive in discriminating type 1 from type 2. Now, young-onset type 2 diabetes is increasing a lot across the globe. This is a very elegant study called the JADE study, which is the Joint Asian Diabetes, forgotten what E stands for, and they're basically looking at type 2 diabetes across South Asia and Southeast Asia, and you can see that in pretty much every one of these countries there's somewhere between a 10 and 20% prevalence of people being diagnosed with diabetes before the age of 40. And I think it's somewhere like about 20% of adolescents in China in some of the most recent data. Young onset type 2 diabetes is a huge problem. So how are we going to differentiate them from the type 1 patients? And of course, their treatment also needs to be different. This is some really nice data from the States, published 3 years ago now, and it just shows that if you take a group of type 1 diabetes patients who were diagnosed before the age of 30, and this age match for type 2 diabetes, and then look at the cumulative survival over the next 50 years, the type 2 diabetes patients do a lot worse. So this isn't just about having high sugars. There's obviously something in this disease process, that, or perhaps the way they're managed, that means that in the long term they have more significant morbidity and mortality. We need to be able to identify these individuals. So there's increasing young onset type 2 diabetes in certain ethnic groups, or in fact in all ethnic groups, but disproportionately in some of them. And the question is, how should we identify the type 1 cases? The clinical criteria are ineffective, but you could argue maybe we don't need to worry about this. Maybe there's just more type 2 diabetes in these ethnic groups. Well, this is the atlas, sorry, it's not the latest one, but this is the IDF atlas, which shows the type 1 diabetes prevalence by country. And you can see that a lot of this is sort of hashed and shading, and that means there's no data available. And I think it's well recognised that there's a lot of data acquisition bias in the type 1 diabetes figures around the world. So we simply don't know how prevalent type 1 diabetes is in a lot of, for example, sub-Saharan Africa and Asia. And of course, even if we knew that, it's fascinating to note that the prevalence of type 1 diabetes in the native population is often different to the migrant population. Now, this is a study from Finland which shows that when Somali individuals move to Finland, their children have the same prevalence and risk of developing type 1 diabetes as native Finnish people. So there's an increasing risk that you adopt in the second generation migrant. So even if we knew about the prevalence and characteristics of type 1 in the native countries, it changes when they come over. Now, that was a bit about type 1. There's also other subtypes to consider. One of my areas of interest in monogenic forms of diabetes. Maturity onset diabetes of the young is a single gene defect that leads to diabetes. It's usually characterized by being diagnosed at young age, having a family history and not requiring insulin. And if you see someone that meets those criteria, you send them off for a genetic test. You do that first because the genetic test can cost up to about £600. So you want to make sure that you're testing the most appropriate individuals. Why do we go to the effort to diagnose this? Well, a lot of the people can manage on a tablet. And there is actually a form of MODY that requires no treatment at all. So you have high blood sugars, but you don't need any treatment. So there's a real benefit to say to someone, oh, your child got diagnosed and they're on insulin. Actually, they can come off of insulin. So what about MODY in ethnic groups? Well, that's another knowledge gap. But I've looked at all of the referrals for MODY genetic testing, and what I've found, and this is submitted, is that of all the white people that were referred for genetic testing, a quarter of them would have a mutation found in one of the genes that could cause MODY. But when the South Asian people were referred for genetic testing, the pickup rate was half of that, so around about 12.6%. And we're looking into why that might be, but it seems like there is more young onset type 2 diabetes in the South Asian group. So in the final 5 minutes, I've talked about how ethnicity might impact on diabetes subtype, but what about variable phenotypes? Well, although I mentioned that ketosis-prone type 2 diabetes is a relatively new thing, actually, the first description came from William Winter in 1987, and this was published in the New England Journal. And in a very elegant study, they recruited 129 black American adolescents with high blood sugars, some of whom had ketosis. And what they noted was that 12 of them were able to stop insulin after the first few months, and this was unprecedented. So ketosis-prone type 2 diabetes is really weird. This is what we thought we knew. We thought that ketoacidosis only occurs in type 1 diabetes. People with type 2 diabetes are not at risk of ketoacidosis because they continue to make insulin. And if you present with ketoacidosis, you need insulin lifelong. That's what the textbooks told us That's what we were doing. What we now know is that, bizarrely, ketoacidosis can occur with type 1 and type 2 diabetes. And some people with type 2 diabetes that get ketoacidosis can come off of insulin a few months later. They don't need any treatment. They maintain normal blood sugars off treatment. This is fascinating because it turns on its head everything we thought we knew about the pathophysiology of type 2. This is a very famous graph from the UK PDS study, and it shows beta cell function on the y-axis and time in years on the x-axis. And basically, time equals 0 is when you're diagnosed with type 2 diabetes. And what you can see here is that by the time you're diagnosed, you've lost about 50% of your beta cell function, and then it continues to decline. Now, in theory, you would be at risk of ketoacidosis once you decline down to 0, but most people die before that happens. What's going on in ketosis-prone type 2 diabetes? For some reason, there seems to be an acute decline, which then gets better after a few months. How does that even happen? So this is a subtype of diabetes that has been initially exclusively described in African Caribbean populations, but now there's increasing recognition in Hispanics, Southeast Asians, South Asians, and there's case reports in white Europeans too. And it's amazing. It means that when we see an African Caribbean patient over at Charing Cross and they've got DKA, we can't really tell them that they're going to need insulin lifelong. We have to wait and see what will happen. There's a lot of work been done into what's going on, why there is ketosis-prone diabetes occurring in these individuals, but they are very difficult to compare because no one has got a clear definition of what a ketosis-prone patient looks like. One of the things that has come out is whether there's a viral precipitant to ketosis-prone, and our collaborators in Paris have looked specifically at human herpes virus 8 and have shown in this elegant publication in JAMA, a bit old now, from 2008, that 87% of their patients had antibodies to HHV8. But this story isn't complete because some of their controls also had antibodies to HHV8. So, in summary, there is a paucity of data relating to the effects of ethnicity on diabetes phenotype, and it's clear from our clinical practice that ethnicity affects both subtype recognition and phenotype. And we might need ethnic-specific criteria to be able to facilitate recognition, but we need more studies, including my diabetes study, to sort of address this knowledge gap. Now, in the UK, we need to work hard to improve awareness of the difficulty in subtype recognition, and the My Diabetes is the first study of its kind to recruit 3 ethnic groups and to study this systematically. Globally, we need the same thing, but we also need to think about access to the diagnostic tools I mentioned. How are people going to do this in developing countries? So going back to my man at the beginning, what kind of diabetes does he have? I have no idea at all. And we wouldn't know until we followed him up and did the relevant tests. So I think I'm going to stop there and just thank my supervisors and members of the team.
Fantastic, thank you, Shivani. So any comments or burning questions or things to discuss from that?
Yes. Is there any point in talking about type 1 and type 2 diabetes? Shouldn't we sort of have a sliding scale? I've got diabetes 1.45.
Yeah, I think that's I can't remember who I was talking to, but I had exactly the same. When we looked at type 1 and type 2, our understanding was very simplified, I would say. I mean, even going back to when we used to talk about insulin-treated and non-insulin treated, we've moved away from that now. But yeah, I think the more that our understanding develops, the clearer it is that there is a spectrum of phenotypes here, and there isn't a clear distinction between one and the other. So yes, I agree with that, but how we would do that and in a way that everyone agreed internationally would probably be the challenge with that one, yeah.
Well, I think there's a point about etiopathogenesis there as well, isn't there? And you were talking about ketosis prone and the HHV8 association. The type 1 diabetes has enterovirus associations, whereas type 2 diabetes is much more an insulin secretory deficit that is polygenic, perhaps epigenomic and obesity and lifestyle related. So they're very different in terms of pathogenesis. I agree that everyone has a degree of insulin resistance and a degree of insulin secretory deficit, but I think drawing some lines between etiopathogenesis is useful, and particularly if we're talking about interactions globally and interactions with infection. I think there's a probably useful distinction, but clinically you're absolutely right, it's much more blurred.
Thanks very much for a very interesting talk. You mentioned a study where some Somalis residents in Finland had the same prevalence of diabetes as the native Finnish population after a generation of having stayed there. Do you think this could be due to adopting a sedentary lifestyle, which would be very different to the sedentary lifestyle of their parents in their homeland, or to adopting certain nutritional habits or other lifestyle issues?
Yes, so I think the answer, the correct answer to that is no one knows at the moment, but given that it would take generations for someone's genetic makeup to change, clearly there's an underlying genetic susceptibility to type 1 diabetes. You know, everyone's got risk and protective genetic alleles. But yeah, by moving over and being exposed to environmental factors, and I don't know if those are nutritional or environmental, then that somehow triggers the onset of type 1 diabetes. Because in the same study, they did look at the genetic risk alleles, and they showed that they weren't dissimilar across the different groups. Yeah, so you might have seen that they mentioned vitamin D in that study. Yeah. Yes. Oh, okay. Yeah. So the question was about changes in sunlight exposure and potentially vitamin D levels. Yeah. Yeah, so they did measure vitamin D levels and showed that I think the levels were quite similar in that group. But vitamin D is one of those things that crops up quite a bit in the pathogenesis of a lot of conditions. And I suspect, like with all of these things, it's going to be multifactorial. Interestingly, when you look at people from equatorial regions, they often don't have very high vitamin D levels because they avoid sunlight. And the more pigmented your skin, the more sun exposure you need to generate the same amount of vitamin D as white Caucasian skin. So I think, you know, it might be something that is associated with, but whether there's a cause and effect, I'm not sure.
The infection effect that you're looking at, the HIV, surely all ethnicities would be exposed to the same virus.
Yeah. So I think I put the HHV8 in because I just think that's quite interesting. It's not clear cut at the moment. I mean, I haven't shown all the data, but even in their healthy control group, some people had HHV8 antibodies. I think probably it's not an HHV8, this is just my personal opinion, it's probably not an HHV8 specific thing, it's probably more a viral precipitant. And we know that in type 1 diabetes, that there's often viral antigen exposure in beta cells. Perhaps for some reason there is another viral insult that triggers it. The interesting thing about ketosis prone that I didn't mention is that there is no precipitant. So a lot of people with type 1 diabetes can develop ketoacidosis if they're unwell, they've got a chest infection or diarrhea and vomiting. So you often take that history when they come in. But people with ketosis prone type 2 felt absolutely fine, and then suddenly like that, they're in DKA. So there is some acute insult to the beta cells, and we just don't know what it is at the moment.
You said that BMI is useful to try and differentiate between type 1 and type 2, but we know that BMI does have its shortcomings as a measurement tool. Wouldn't measuring someone's body fat percentage be less discriminatory because it's not based on someone's weight?
Be more discriminatory?
Be less discriminatory because it's not based on someone's weight.
So you mean it
You
would
mean
be
better discriminate
better
between types of
discriminate.
diabetes?
Yeah.
But yeah.
I know what you mean. Yeah, probably. No one's done the study. One of the things we are doing in the My Diabetes study on a subset is we're measuring body fat distribution, but by bioimpedance, so by no means the best measure. No one's looked at that. I think the counter argument to that would be availability and accessibility. you're making these decisions on usually acutely unwell patients out in the community, and you probably won't have access to that. But you know, we're looking at things like waist circumference as well. So there's not going to be a straightforward answer to that, I think. But yeah, I think it might be better.
Fantastic. I'm sure we'll come back to some of those themes. So it's a pleasure to introduce John Dragoni, who is a senior lecturer in the Faculty of Medicine. He and his group have worked on glucose in airways and the risk of lung infection in vivo, and it's an absolute pleasure to hear him talk about that elegant work.
So, my name is John Dragoni. I work up at St Mary's in mucosal infection immunity. So I'm an immunologist. I principally work on viral infections. I have a small niche unit, which is essentially Simran, who's sitting there, who works on bacterial infections, particularly in diabetes. And so we kind of work on a range of different infections and vaccines and things. So if you're interested in looking at respiratory infections, we are always interested in collaborating. So the kind of founding point that we started at is that individuals with diabetes are more susceptible to bacterial lung infections. And so this is data generated by Alison Holmes and Luke Moore, and it's based on the two critical care units, Hammersmith and St Mary's. And they've got a large and interesting database which they can look into to see various different correlations of who's coming into the intensive care unit, what infections they have, what type of bugs they have, and they have a range of kind of well-characterized clinical data about these people. And we were interested in looking at whether the people who get into intensive care, is there a greater risk if you have a blood glucose level over 11.1 millimolar. And what they saw was that there was a significantly greater percentage of people with so if you have a higher blood sugar, so if you're hyperglycemic, you're more likely to have bacterial colonization if you are hospitalized into the intensive care unit. And of the bacteria that they found most commonly in the colonizers, so the bugs that do colonize these patients, the one that actually interesting, the one we're interested in, which is called Pseudomonas, is one of the most common types. So patients with diabetes, or with a hyperglycemia, I should say, are more likely to have bacteria, or they detect bacteria in the lungs of these patients more. And so why is that? So the airways, upper and lower, are awash with biochemicals that can support bacterial growth. So we've recently done a pilot study, and this is looking at two different methods to sample the upper and lower airway for their metabolomic profile. So what we did is we did two different ways. The first is we took basically little strips of blotting paper and put them up the noses of people, and also they got bronchoscopes, so they shoved down into the lungs, and measured every single biochemical that you can pick up by mass spectrometry. And so we found a huge range of different things. It's an incredibly sensitive technique. There were 8 people in the study. We found there were 2 people, one who was a social smoker and one who was an ex-smoker, that in their induced sputum we could find nicotine metabolites. But in my nasal secretion, there were also nicotine metabolites. I haven't smoked. I possibly walked past somebody smoking from my lab on the way to the clinic that morning to get done, and it may just be in that process just by breathing it. So it picks up a whole range of everything. But in terms of this study, what is of interest is that you start picking up a large number of amino acids, of sugars, of citric acid components, so energy components that bacteria can use to grow upon. And the hypothesis that we started thinking about was this, is that normally, so in healthy patients, the airway glucose is very tightly regulated. So the airway glucose levels are 12 times lower than the blood. Basically, the lungs are actively pumping sugar out of the lungs and into the blood. Diabetes patients have, and I'm sorry if I'm using slightly the wrong terms, I'm aware that I'm not an endocrinologist, so I apologise if I'm using totally politically wrong phrases, but people with hyperglycemia, and particularly patients with both diabetes and cystic fibrosis, have much higher levels of glucose in their lungs. And so the hypothesis that Simran's been working on for the last 4 years is that the risk of bacterial infection in the lungs of patients with diabetes or hyperglycemia, is increased by the elevated surface liquid glucose levels. Basically, there is more sugar in the lungs, so more bugs can grow. The equivalent, it's like leaving the lid of a jar of jam open. You're basically providing a rich growth media, and the bugs pile in and grow better. So is this hypothesis supported? The way we tested it was actually by looking at a particular bacteria called Pseudomonas aeruginosa. Pseudomonas isn't particularly a colonizer of normal healthy lungs, but in people with chronic inflammation, particularly CF, it does then, it's an environmental pathogen, but it can then grow in these kind of slightly unhealthy lungs. And the reason, one of the reasons we're using it is it's a nice genetic tool. It's very easy to change the genes within Pseudomonas, and I'll explain more about that later. And so we are in vivo biologists, so we use mouse models for most of our things, and we're looking at a mouse model of acute hypoglycemia. There have been studies done using genetically obese mice, so they're mice with leptin receptor or leptin deficiency called OB or DB, and these are the kind of big fat mice, but they have systemic things wrong with them. So we wanted to look at something where we're looking specifically just at the glucose. And so we use this horrible chemical called streptozocin, which kills all the beta cells in the mice and induces a very acute state of hypoglycemia. And what we argued why this is a relevant model is that it takes away maybe some of the kind of long-term effects of hyperglycemia on immune response, and we're just looking at increased sugar in the lungs. And so we performed streptozocin treatment, increased both blood and airway glucose. So this figure shows the blood glucose. This is 2 weeks after the initial streptozocin treatment, but this is now time relative to our infection. And what you can see is that the treated animals, so the animals in which we have induced hypoglycemia, have a much higher blood glucose, but also they have a much higher airway glucose. So pushing up the amount of sugar in the blood pushes up the amount of sugar in the lungs. Basically, the pumps that are normally pumping it back out the lungs are going to be overwhelmed and can't just get rid of it out of the lungs. And then we came in with our bacterial infection, our Pseudomonas infection, and you get a significantly higher acute level of bacterial infection, and it also takes longer to clear. So in our hypothesis that more sugar equals more bacteria, this is supporting this model. We then looked at one of the kind of common anti-diabetic drugs, metformin, to look whether it could reduce the airway glucose and therefore reduce the amount of bacteria. So these were mice treated with metformin. They were given streptozocin, so we induced type 1 diabetes, type hypoglycemia, and then they had a single shot of, I'm looking at someone, two doses of metformin, and that doesn't change the blood glucose, but it does significantly reduce the airway glucose and brings it back to the same as the naives. And then when these animals were treated, were infected with Pseudomonas, we then had a proportionally decrease in the bacterial level in the lungs. So this supports the idea that the reason why there's more bacteria is because there's more sugar. But is it glucose? So glucose is definitely elevated in diabetes or hypoglycemia. And there are two possibilities, and these are obviously not mutually exclusive. But we're sort of taking a bug-centric view. The first is that the elevated glucose suppresses immune function, and that is definitely the case. There are going to be lots of strange things happening to neutrophils, happening to the macrophages with too much sugar, changing the whole metabolomic profile of these cells. We haven't drilled down into that in this study, and it is, there is more work to be done there. But the second part is that the elevated glucose supports bacterial growth. And the way we decided to look at this was to generate glucose utilization mutants. So the genome of Pseudomonas is well characterized, all of the genes are well known, and so we could pick out the ones that we believe are involved in glucose uptake and metabolism. And so Simran picked out four, this probably should be her presenting her work, especially she's just passed her PhD, but I picked out 4 mutants. So there was starting from the outside of the cell and then working on their way in. So there was a POR protein, which allows the glucose to be pumped into the cells. There's an ATP binding cassette. So basically, there's a very outer membrane which stops the glucose getting in without the POR. There's an inner membrane, which is the GLTK protein, pumps it across. There's then a glucokinase, which is part of the biochemical pathway, and also GTRS, which is, again, a transport sensor. So the aim was to take out various parts of the pathway which a bacteria would normally use to uptake and metabolize glucose. So Simran generated these mutants and then did some growth assays. So testing them in normal complete, so for those who are not microbiologists, a lot of the bacterial work is grown in massively rich media. So because the aim of the study, most bacterial studies, is just to grow lots of bugs, we put them in super rich media. It has too much of everything. So in the very rich LB media, this top diagram here, they grow normally. So it's not causing a kind of global defect in the growth of the bugs. But if they're then transferred into M9, which is a salt media, and only given glucose, so only given a single carbon source, the mutant bacteria then did not grow as well. So without the ability to use glucose, they then cannot grow in this kind of minimal media. So what this shows is that the bugs we've generated need, in the presence of glucose, they don't grow. So therefore, we've knocked out their ability to utilize glucose. That therefore gives us the tool to investigate, is the elevated glucose in the lungs what's driving the increased bacterial colonization? We also looked in a slightly more developed model, which is a co-culture model. So this is taking an epithelial cell line, so a primary cell line, and growing up in vitro, basically a monolayer cell. So it looks a little bit like what the lung would look like, or the surface of the lung would look like, and then adding bacteria onto the top of these. And in these cell cultures, you can change the amount of glucose underneath the cells or on top of the cells. So you can start kind of making changes to make it look a bit like a hypoglycemic lung. And again, if you increase the amount of glucose in this model, you see more growth of the wild-type bacteria, but none of the mutants. So you're increasing the amount of energy that's available, but these mutant bacteria cannot use it to grow. And so the kind of proof of the pudding was then to test it in our hypoglycemic mice. And what we saw was that, again, if we put wild-type bacteria into wild-type or hypoglycemic mice, you get a significant increase of bacteria in the hypoglycemic mice. But the knockout bugs were not able to utilize this extra glucose, were not able, therefore, to grow and expand. So what we're seeing is that at least part of the increased bacterial load in this model of hypoglycemia is being driven by the ability of the bacteria to utilize glucose. We have then taken a step forward from this, and the idea is that, well, maybe if you target the ability of bacteria to use glucose, it might make a novel antibiotic target. It might be that the glucose uptake pathway could be important in terms of if you knock that down in certain patients, or sorry, in the bugs infecting certain patients, you then might get reduced disease, and therefore it's a novel antibiotic target. And what Simran's been doing recently is using a tool called TRADIS, which is a metagenomics tool. So it's using kind of high throughput genetics. You start off with basically a whole population of different bacteria that have knockouts in individual genes. And then you throw them into your minimal media, and the ones that come back out are the ones that are able to use the thing that they're growing in. So in this case, we've grown them in a minimal media with glucose, and we're looking for what genes are disappearing from the original library. And so she's beginning to find more gene targets possibly through this route. The final bit is just to demonstrate where we're going forward. And so it's not only diabetes that this has a role in. So like in diabetes and COPD patients have increased bacterial and viral infections. And if we measure the glucose in the sputum from COPD patient or controls, we see that even compared to smokers, age-matched smokers, you're getting a significant increase in the sputum. So what we're now arguing is that maybe COPD is actually also, infection in COPD may also be driven by this increased inflammation and increased sugar in the lungs. And this amount of glucose increases with the severity of the COPD. And this is leading, hopefully, to a trial where we'll look at the role of metformin in COPD, and whether you can start reducing bacterial exacerbations of COPD with the use of metformin. So in conclusion, elevated airway glucose correlates with elevated bacterial load. When the glucose is reduced, the bacterial load is reduced. And when the bacteria can't use the glucose, there's no increase in load in the hypoglycemic mice. And this suggests that in part the elevated infection in diabetes is driven by increased glucose in the lungs. And that's it. It's just to acknowledge the hard work Simran has done to all of this, and our collaborations with Alan and Alison and Patrick, all on different campuses, have contributed also. Thank you.
Thanks, John. Those are beautiful data. Any comments or questions about those? So the COPD data you showed at the end, so glucose is higher in the airways in people with more severe COPD.
Yes.
Is that related to their dose of inhaled steroid?
It's related to inflammation. So if we correlate the amount of inflammation of inflammatory markers like any cytokine, CRP, that correlates very tightly with the glucose. So basically, inflammation will open up the spaces between the airway epithelial cells, allowing the sugar to cross from the blood into the lungs more often. So any inflammatory insult, even in healthy patients, will increase the amount of airway glucose. And that may be a protective thing anyhow. It may be that the airway leukocytes, the white blood cells, need glucose to function once they're in. So part of the kind of invasion into the lungs, actually, they need the kind of sugar kick to get going in the lungs.
I was just wondering if in which medium, assuming everything's using in the algae, yeah, so glucose
you might have said it, so sorry if I missed it, but what's the relationship between airway glucose and blood glucose? Is there a lag? Are they coupled together? Is it uncoupled?
So in the bit I know is that in the healthy patients it's 12 times lower, and I don't know if it's a linear relationship. If you then go up to higher baselines, you then have high, is it proportionally still 12 times lower? I don't know whether there's a point at which the there's pumps called SGLT which actively remove it. I don't know whether they are going to reach a point where it's saturated and it kind of then caps out and it just kind of keeps them going up and up.
So I don't know if you want to comment on the sort of global relevance of what you've done. You've done some beautiful, very elegant work. We talked at the last meeting about the interactions between TB and glucose worldwide, and you've hinted that this is potential for antibiotic targets. Are there any other ways in which this can have real global impact?
I suppose simplistically, better management is always going to lead to better reduced infections. No. I haven't thought about that question. It's a good question. I haven't thought about it.
Sure. And the other thing, you used a streptozotocin model because you wanted to take out the immunopoiesis of long-term hyperglycemia. Yep. Are you going to try and add that back in and see how that is additive, or if it's additive?
I think we'd need to go back into the obese mice to do that better, because the streptozosis is quite a nasty model, and I think probably they would not do well over long term. So I'd probably have to move into the other systems to look at that.
Just picking up the issue about COPD, it always seems to me once the airway epithelium has been disrupted, you're bound to get more infection. And it sounds as what you're saying is you're bound to get more glucose as well, because it will leak over much more quickly. I'm just trying to think there's also, of course, the problem that you get a lot of comorbidities, particularly in COPD. So other chronic diseases are very often also associated with COPD. And I'm just trying to think what the sort of long-term implication would be. And my memory, a long time ago, of trying to grow bugs in the laboratory, one of the old-fashioned things before they had all the new technology was that you grew the bugs in different sorts of sugars to try and discover which sort of bug it was. And so I guess that some bugs are going to respond quite well to rich glucose, and others aren't. Maybe that explains to some extent the pattern of overgrowth that we get in big.
And we're thinking about it because what we were going back to this data set, what we wanted to look at was whether we could isolate individual biochemicals that would support growth. And you can do it very easily in Pseudomonas, but Pseudomonas is an environmental, essentially it's an environmental pathogen. So it's quite the opposite of fastidious. I can't think of the appropriate word. It will use lots of different media because it finds itself in lots of different places. The ones that are specialised into the lungs, so NTHI and staph, are difficult to grow in the lab and require a very broad media. So maybe that the ones that are good colonisers have started kicking out some of the kind of, they're autotrophs in some way. So maybe because they can get the energy they need from their very specific environment of the lungs, they're then less genes, they can start losing some of the kind of the genes you need to make other things. So our common carriage commensals probably have less ability to make things from scratch and other things, and by losing those genes they become fitter, and it's kind of out-competing it. I think that probably would be I guess that's very obvious to a microbiologist, and I'm not, but to kind of get to that same conclusion has been quite interesting to kind of get there.
So just a quick question. How do you know that the presence of the pathogen in the lung itself isn't altering the local metabolic environment, i.e. the presence of the Pseudomonas itself is causing or contributing to a raised glucose in the lung, and that then itself is obviously. And also, the second part of the question is you haven't discussed the fact that Pseudomonas morphs and changes phenotype into mucoid and non-mucoid phenotypes. That could be very different lung environments as well.
So the first part, so it will be generating inflammation and therefore driving up the blood sugar.
So why isn't that being included
In the lungs,
in your COPD patients, or bronchiectasis patients, or CF patients, or CF patients?
and it probably is. I think so. LPS will drive up the LPS alone is enough to increase the inflammation and increase. So yes, it will be cyclical. It's contributing to its own growth. So that is definitely happening, and these were COPD patients who were stable. When actually, I didn't show it, but when they're virally, so this is Patrick's, Malleus and Seb's data that we've been collaborating with, when they're virally challenged, when they're given rhinovirus deliberate, and this is in the quite mild, the glucose then spikes up even further, and the healthy patients it goes up a bit, the COPD patients it goes up much more. So maybe they've got more flora in there to start with, and it's all kind of exacerbating. The second part, we didn't see it in our thing because it's a very acute model. So with a lot of these mouse models, it goes in and it clears very quickly. So I don't think there's time for it to change from being a kind of planktonic to a biofilm type thing.
So the problem is that all these patients that you're talking about have chronic lung disease and have chronic infections who are not acute. Those healthy people cure Pseudomonas if you know that, or they never get infected.
Yeah.
So it's a very different environment in that kind of chronic environment, and the Pseudomonas has changed phenotype completely. So it's very hard to draw conclusions from a acute model about what might be happening in a chronic environment. That doesn't.
And we looked at some CF-derived Pseudomonas, and there wasn't, and I think because they react so quickly, there wasn't any difference in our kind of growth models. So it's not like it's a long-term switch and they're shutting down, losing genes, they're just shutting them down and they can turn them back on quite quickly as well. But in principle, if you could cut the amount of food that is for the bugs, it may be that the host could then get a foothold ahead, but we don't know. Yeah. Yeah.
Have you considered the air clearance rate for lungs?
No. So if things are there for longer, then they can kind of grow better. No, we haven't. And mainly because most of what we've done is mouse work. The human stuff is quite new and kind of changing.
Great.
Thank you very much, John. To finish, the third presentation is me. So I'm going to talk about type 2 prevention work that we've done in India. At the last session we saw some beautiful data of the burden of hyperglycemia and obesity worldwide, and I think this follows on very nicely in how we might tackle that burden of diabetes and how we might work pragmatically to prevent diabetes. So you're all very aware of the diabetes epidemic, of the prevalence of type 2 diabetes and of how that's rising, and in particular how it's rising in developing countries. And if you look at the prevalence there in South Asia and Southeast Asia, it's up to 8.7%, and in some pockets it'll be over 20% prevalence of type 2 diabetes. This is a significant global burden, both in terms of health, morbidity, mortality, and in terms of healthcare resources. So the question is, how do we pragmatically address this? How do we prevent diabetes on such an enormous scale? In order to think about prevention of diabetes, there's a few questions to consider so that we have the optimal strategy to do so. So questions are like, what are the early changes? Is it insulin resistance or is it insulin secretion that is the thing that changes first? Is prevention even possible? Are the results from prevention studies generalizable? So if we can prevent diabetes, for example, in a mouse model, and we can very frequently prevent diabetes in mice models, is that generalizable? Is it translatable? And if you can do it in small populations, can we do it in larger populations? We need, first and foremost, in some ways, from a clinical perspective, to define who is most at risk of developing type 2 diabetes. We need to detect those people on a large scale, and whatever we do must be both clinically and cost effective. So there are some huge challenges around what seems to be a fairly simple task of preventing people progressing to glucose intolerance. Broadly, there are two strategies that have been looked at in the literature. There are behavioural interventions using diet and physical activity primarily to modify behaviour to change the risk of diabetes progression. And then there have been pharmacological interventions using pharmacology to change glucose metabolism and prevent progression to type 2 diabetes. So this is a selected highlights. This is by no means all of the diabetes prevention studies, but these are the three major diabetes prevention studies. First, there was the Beijing study in China, followed by the DPP in the US, and the diabetes prevention study in Finland. And it's marked that these are all lifestyle studies. So these were not pharmacology. These were very simply telling people to eat less, to eat differently, to do more physical activity, and to address risk factors like smoking and salt in their diet. They all selected people with abnormal glucose tolerance, but before they had frank diabetes, so so-called pre-diabetic states, and the lifestyle interventions went on for somewhere around 2 to 6 years. And it's really striking that these were massively effective. So both the US and the Finnish diabetes prevention programs reduced the progression to type 2 diabetes by 58%, which is a huge impact. The US diabetes prevention program, however, cost $200 million for 3,000 people. That's probably not meeting the key metric of cost effectiveness. However, the principle is there. So we know that we can do it, and there are some beautiful mechanistic studies from these lifestyle studies that suggest that it's those people with an early insulin secretory deficit that have the most to gain. So we do have some of the clear answers about how we address risk, but what we don't have is generalizability from these studies. If we look at the major drug studies, again, we have the US Diabetes Prevention Program, which had 2 drug arms. It had a metformin arm and it had a troglitazone arm. Many of you will not be familiar with troglitazone. It had a checkered history in its brief life before it was withdrawn because of some fatalities from liver disease. There was the Stop NIDM study, which used acarbose, and then there was, as I said, the troglitazone arm. Again, these were significantly effective in terms of reducing the progression to type 2 diabetes, but what I still find intriguing is that pharmacology is less effective than behaviour. So if we can engage people in changing diet, reducing diet, and physical activity, we can do more than pharmacology can. Though it's worth noting that these were still pretty significant reductions in the progression to type 2 diabetes within these studies. So who is it that we need to address? So if we look globally at glucose, at fasting plasma glucose as a categorical variable, and we look at the 5-year incidence of progression to type 2 diabetes, we can see that around 5.4 millimoles per litre, the risk really starts to take off. And it's when you get up to a fasting glucose between 6 and 6.9, your risk of developing type 2 diabetes in the next 5 years is somewhere around 30 to 40%. And that's a really significant takeoff, obviously. So what we need to be trying to do is to address these people who are at highest risk of developing type 2 diabetes, though conversely, in the lifestyle study, it was the people at the lower end who had the greatest to benefit from participating, and these are the people who are most likely to revert to normal glucose tolerance. So the challenge is selecting people with abnormal fasting glucose or abnormal glucose tolerance, but trying to catch them before they're right at the upper end, where addressing their risk is very difficult. So if we move across and take India as the example, and the reason for that is this is where we've done the study, India is fascinating because it has essentially skipped the landline. It has gone from a telecommunication system where landlines were used in cities alone. It has missed out the stage of having an infrastructure of landlines throughout large rural areas, and it skips straight to mobile phones. And the mobile phone usage in India is incredible. These are data from 2014, but in 1.2 billion people, the mobile phone usage is enormous, and there are over 880 million active mobile subscriptions. In some of the urban areas of India, the mean number of mobile phones that people have is 1.2. So most people have more than one phone. So this gives us a fantastic way to reach a large volume of people pragmatically. And that is exactly what we've done. So we in collaboration between Imperial and Rami Ramachandran in Chennai, we set up a UK-India Education Research Initiative several years ago using a text message intervention, a very simple text message intervention, taking people with impaired glucose regulation and randomizing them to receive regular text messages that aim to replicate the generalizable lifestyle changes that we saw in the earlier effective lifestyle studies, but to do so in a pragmatic way. And the text messages are around 350 messages which are culturally specific, which deal with diet in terms of both amount and content, so reduced fat, reduced carbohydrate and increased fibre, increasing and encouraging physical activity, reducing salt and preventing smoking where possible. So in this study we ended up with 260 people assigned to standard care and 271 assigned to the text message intervention. These were all men, all who worked for the Indian Railways, and all of whom were recruited very rapidly by a pragmatic approach to measuring glucose, and the primary outcome from the study was progression to type 2 diabetes. The text messages were grouped into different categories according to the trans-theoretical model of behavioural change, which puts people into a category of pre-contemplation, contemplation, preparation, action, and maintenance. And what that means is if you're considering giving up smoking, you start off at a pre-contemplation phase where you are aware that you're a smoker and aware that smoking is probably not great for you, but haven't really thought too much about stopping. Contemplation, you start to scratch your head and think, maybe I should stop. In preparation, you go and see your GP and say, I think I'd like to stop smoking. And in action, you have initially stopped smoking, and that's the very high risk stage because that's where people can relapse back to an earlier stage. But if you are able to get through the action phase, you're into maintenance and you've become a non-smoker. And you can use the same approach to behaviour change for diet, for exercise, or for any other behaviour or lifestyle. So the text messages that people received were very clearly aimed at what stage of the trans-theoretical model they were at. There's no point saying to someone who's never even thought about changing their diet, great job with your fibre today, because they're probably not going to know what that means. So the text message content was to a certain extent individualised and fitted the trans-theoretical model, and most people received messages 2 or 3 times a week. This is the population, so as I said, it's an all-male population around the age of 46. Most of them were skilled, and as you might expect in a South Asian population, there was a high prevalence of family history of diabetes. But as Shivani has said, these were not particularly obese people, BMI of 25.8. is slightly above the normal range for South Asian population, but is not as high as it would be if we did the same study in the UK, which we are doing at the moment. Blood pressure was reasonably normal, and a quarter of people were receiving antihypertensive drug therapy. One of the prerequisites of entering the study was having abnormal glucose regulation, so you can see most people had a 2-hour glucose that was above the upper limit for impaired glucose tolerance of 7.8. Lipids were fairly normal, and this was a slightly insulin-resistant population. So if we have a look at the primary outcome of what happened over the mean follow-up of 2 years, you can see that in the control group there was a sorry, if I have to go back here. There was a significant reduction in progression to type 2 diabetes in the intervention group, and the hazard ratio was 0.6. So there was a 36% reduction in the progression to type 2 diabetes from a simple, pragmatic text message intervention delivered to around 500 people. And this was statistically significant at the 2-year period. And if you compare it to the 58% that was seen in the US diabetes prevention program, it obviously doesn't meet that. But given that it didn't cost $200 million, it cost less than £1 million and was delivered pragmatically and widely, I think that represents much more cost effectiveness. Interestingly, none of the secondary outcomes achieved statistical significance. So people didn't particularly lose weight, blood pressure didn't particularly change, lipids didn't particularly change, and people weren't particularly more physically active. What did change was diet, and the thing that people mostly adhered to when we looked at adherence scores was the dietary changes. So that suggests that people found it easiest to respond to the dietary intervention rather than anything else, and physical activity really didn't change at all. So despite us telling people to get off the sofa, stop watching TV and go for a walk, people didn't really bother, but they did eat less and they did eat differently. When we look at who is most likely to benefit, and this comes back to one of those questions about what is an effective strategy for preventing type 2 diabetes, as you'd expect, those with higher 2-hour glucoses were harder to address and were more likely to have incident diabetes within the study. Those with a higher HOMA score for insulin resistance were more likely to develop incident diabetes. Those with a lower insulinogenic index, those with higher changes in BMI and greater changes in dietary adherence, and that's sort of what you'd expect. So those people who had the higher glucoses, were more insulin resistant, had the higher BMIs and were less dietary adherent during the study were most likely to develop type 2 diabetes during the study. So we showed that mobile phone messaging is a very effective strategy for reducing type 2 diabetes in a developing nation, and the relative risk reduction was 36%. And if we sent those messages to 11 people, we would prevent one incident case of type 2 diabetes. So doing a very rough head count in this room, if you all had impaired glucose regulation, over 2 years we could prevent 3 cases of type 2 diabetes. So this is obviously early data. These are only men, which is one big problem with the study, and it was reasonably small, but we are now conducting the large powered study both in Chennai and in London, and we're fully recruited and we'll report next year, and we'll tell you if it's effective in a larger population, including women, both in the UK and again in Chennai. The Chennai data I have seen, but I'm not going to tell you the answer. So very happy to discuss that, but hopefully it gives you a flavour of how we might address this challenge, this global challenge of type 2 diabetes, and how we might think about more pragmatic ways to address it than spending $200 million to address 3,000 people. So I'll stop there. Shivani, John, I don't know if you want to come up and we can, if there's any other issues or wider questions or wider discussion points that anyone wants to bring up.
It just occurs to me, it's still quite expensive for a developing country. And have you thought about how you could get it even more as a kind of mass tool? Or is it inevitable it's going to cost?
No, I mean that's right. So the most pragmatic way to do this is to say we're not going to use the trans-theoretical model. We're not going to try and be fancy about behaviour change models. We're not even going to do risk scores. If we assume that in a large population where there's a huge risk of type 2 diabetes longitudinally, we're just going to send a text message to every mobile phone. So everyone who buys a mobile phone is automatically going to receive 2 messages a week that encourage behaviour change. Now, I don't know if that's effective, because that's not what we're doing. We're being quite focused, we're doing risk scores, we're being very clear about our population coming in. But the most pragmatic, scattergun way to do this is to say, we're just going to send a message to everyone. We're not going to be choosy. And that isn't free. Sending a text message does cost a small amount, but if you engaged Vodafone and the very large providers, I'm sure there's a way to do this without it being as expensive.
Well, that goes on to my second question, which is why not primary prevention? Which obviously is a rather different thing, and the motivations are different.
Yeah.
And I suspect the design of the campaign is different. But if it's a very prevalent issue, that's even cheaper if you get it going. It may be less effective per message sent.
Yeah, no, absolutely.
It might be more effective.
Yeah, so if you take people with normal glucose tolerance and aim to... So what I was sort of suggesting is that if you're at the lower end, it is easier to prevent diabetes. So why not take people at the even lower end and try and instill behaviour change from a much earlier stage so that it isn't really behaviour change. This is instilling the first behaviours of physical activity and diet. Absolutely, I mean that would be fantastic, wouldn't it? If we can prevent a lot of the behaviours and lifestyle that are associated with risk. I don't know if it's effective, but there's only one way to find out.
That's a good question.
Yeah, no, absolutely.
I think it's a great idea. I'd just like to ask you a couple of questions. One is,
Sorry, I couldn't hear. So, if we think that the major cause of death in diabetes is cardiovascular disease, and if we think that glucose is not a particularly important metric early in disease, and there are people who would argue, I would disagree, but there are people who would argue that glucose isn't particularly important at all in type 2 diabetes and glucose-centric treatments are not required, then what we're really trying to do is address a disease where cardiovascular risk is very high that happens to be associated with some glucose occasionally. So if we're going to do that, we really need to be addressing cardiovascular risk, not just glucose risk. And I suppose this comes back to your point, Peter, that if we can do primary prevention for diabetes, we're probably doing a population primary prevention for cardiovascular disease as well. And if you can stop people smoking, then you're doing it for COPD. So there is potential here in this intervention to not be glucose-centric about it. That was the primary outcome in that study. But we can be, when we have a powered study or large enough study, we're able to look at cardiovascular outcomes as well. So I think the concept is trying to look forward at the next study and to say we need to be able to look at cardiovascular outcomes. And that's why lipids was one of the secondary outcomes as well, though it didn't change in that study.
and just a bit provocative, you could send a text message to food processors.
Send a text message to what, sorry?
To do food processors and food.
Yeah, send text messages to the food lobby. Yeah, no, absolutely. Reminding them to not put as much refined sugar into everything. Yeah, I'm not sure they'd read them. Sorry, yeah.
It's a good question about the DPP program.
Yeah.
What were they doing that cost so much?
How were they doing that?
What were they
doing?
Yeah.
So the DPP had a set of goals. So you had to, or the goal was to lose 7 kilos over the course of the study, and you had to increase your fibre to 15 grams per 100 kilocalories. I'm not going to remember them all. You had to do 30 minutes of exercise 5 times a week. And these data were collected very, very frequently. And if you were in the intervention group and you were not meeting your targets, a research nurse on the DPP would come round to your house, bang on the door, and bully you into meeting your targets. In addition, there was group education and there were one-to-one exercise programs as part of this. It was hugely resource intensive. It was mostly people. What is slightly interesting from a political perspective is that it was delivered at the time by United Health, the chief executive of which at that time was a man called Simon Stevens, who now has a job over here, I think, doing something. But one of his focuses in the NHS in the last year, and one of the things he put in the 5-year plan before the general election in 2015, was diabetes prevention. And he has expertise and form in delivering it, albeit in an expensive, non-generalisable, less pragmatic way. So the NHS Diabetes Prevention Programme, which he and Jonathan Valabji have led, has come out of some of his experiences delivering the DPP. So there is a sort of a political story there that follows on from those data.
Was there like learnings that you could take from that to be applied in a...
So I think the learnings that we took from the DPP and we're trying to apply is to meet the same targets of 7 kilos weight loss and to change the fibre intake to 15 grams and to do 30 minutes. So to take those metrics, because those as outcome metrics in terms of physical activity and diet are clearly effective. So if we can implement them but in a much more pragmatic way, then those are the learnings. The generalised findings that came out of all of the studies about the people with the lower glucoses were the ones who were easiest to revert to normal glucose tolerance are consistent across the studies. But yeah, I mean, I think we've learned from the DPP what the effective strategy is.
In terms of primary care screening and prevention programs achieving really good outcomes, and very cheaply, very cost effectively. Do you think the example of the Cuban program has any lessons for the UK or for other more developed economies?
I think you need the microphone because I don't know anything about the Cuban program. Tell us.
Well, apparently in Cuba there's a widespread prevention program where nurses and early doctors go round to people's homes and ensure that the behaviorally, in terms of things like diet and exercise and other behaviors, they are keeping up to the required targets, and that does achieve really good outcomes in terms of prevention of things like diabetes and cardiovascular and other diseases, quite cost effectively compared to other developed countries. So I was wondering if, because Cuba is divided and disregarded as, well, a basket case politically, but their public health does achieve really good outcomes. I was wondering whether that would be a case of what's regarded as reverse innovation.
Yeah.
Whether it has any relevance for...
I'm sure it does. I'm not aware of that. I'm sorry, so I can't really answer the question, but it sounds like it's a fantastic programme and it's certainly something we can learn lessons from. I suspect the targets are very similar in terms of what it's trying to achieve, but if it can do it in a cost-effective way, then certainly we should be looking at that and trying to learn from it. Do you have a question?
Yeah, one question. In your study, so was there any shooting feedback from the patient population or the people that you subjected to see about what types of messages worked and what didn't, and how you might tweak that to make it even more effective?
So it looked like, so the question was which messages were effective and what was the feedback about content, is that right?
Yeah.
So this always slightly surprises me. If someone texted me 2 or 3 times a week to nag me to do something, I would change my phone number. But what is really fascinating is that acceptability is really high. People didn't complain, and in the study we're doing over here, people are not complaining about the messages. And I find that surprising. The data suggests, in terms of adherence, that it was the dietary changes that were the things that people were most able to achieve. And the fact that there weren't changes in weight or physical activity suggests that those ones may have fallen slightly on deaf ears. So perhaps it is as simple as changing components of food, which comes back to your point about texting the food lobby. But I guess if we could look more closely at that, and bear in mind this was a feasibility study in reasonably small numbers in men only, so it doesn't tell us the whole story. I think if we were going to focus on anything for a larger, more pragmatic study of a huge population, we'd probably focus on the dietary issues, because I think those are probably the most addressable, and with reinforcement, the ones that are most sustainable. But yeah, acceptability was enormous.
Given that the food provider in most households is going to be female rather than male, is there any sense in reinforcing that message through the family unit rather than just the individual?
Well, you say that, but we delivered messages only to men and they changed their diet. I think there's a load of nuance about how we deliver this to individuals and family units and how we do it more effectively to address risk across the family, the wider family, and the large population.
Even the familial risk.
It makes a huge amount of sense, doesn't it? 50% of people in that study had a family history. So if we can address a family by delivering the messages to one or two key individuals, regardless of gender, then that is obviously a much more powerful intervention.
The question for Shalani really is that, so in natural phenotypes, there are a number of population-based surveys that ought to have quite a lot of the information that you're getting, and I was just wondering whether you've talked to people like John Chambers at Ealing or talked to the people in the SABRE study.
Yeah, so we've certainly had discussions. I think the problem and we've actually thought about recruiting from them as well, but actually I'm more interested for my research in the younger onset group. And SABRE and Lollipop, for example, looked at South Asians who were, diagnosed at any age, basically, or they had quite a late cut-off. And I haven't looked into this, but I imagine the older you get, the easier it does become to separate out phenotype. I could be wrong. But for me, the question arose really from my experiences in the clinic, and they are really in this younger age group of under 30. But yeah, there are some really elegant studies beginning to come out now, looking at phenotype in a very systematic way, and I think we'll learn more and more from them.
I went to a lecture on epigenetics last night, and it's a very interesting observation that if a fetus in utero was subjected to low amount of nutrient intake, they were, when they grew up, or as they were growing up, they were susceptible to metabolic diseases such as all Western disease, diabetes, and obesity. Have you considered epigenetics?
Yeah, it's something I'd love to do, and I think to be able to do that, the study that I've set up at the moment, which is looking at things cross-sectionally, might not be the best way, and we probably need to do a prospective study to look at people. But I think epigenetics is fascinating, and what I'm seeing in the My Diabetes study is that where someone has got two parents, and this applies to every ethnic group, I've seen it in white Europeans as well, if they have two parents with type 2 diabetes, perhaps diagnosed in their 40s or 50s, so not particularly young onset, there's this sort of genetic anticipation effect such that the child develops it maybe a decade earlier. And there is some work to suggest that that is driven by epigenetics and in utero changes, if the mother had gestational diabetes at the time or even type 2 diabetes at the time. So. Yes, and the opposite is true as well, yeah. Yeah. Yeah, yeah. And I mean, I think there's some work to suggest as well, because the beta cells are very sensitive and very metabolically active, and there is some work to suggest that if they are put under stress for whatever reason, because we're born with a finite number of beta cells, and by the age of 20 they all start dying. So periods of metabolic stress might, for example, kill off a few extra and render you more susceptible to developing diabetes later. I don't know.
It could be inclusion of thrifty gene as well.
Yeah, the Dutch famine study is fascinating, isn't it? So you've got thrifty phenotypes and thrifty genotypes. I think we haven't quite unpicked yet whether that is a beta cell proliferation in utero issue, and you just have people who start off with a lower insulin secretion at birth and hit diabetes earlier, or whether there's epigenetic methylation in utero or changes that we're seeing in utero. Yeah.
Because I think there's, the thrifty genotype, for example, in isolated populations as well, for example, the Pima Indians or the Nauru island group, that's often there, but so the actual genomic DNA hasn't changed, obviously, so it's going to be perhaps a combination of in utero exposure and then epigenetic changes throughout your life. I mean, they don't just stop in utero, so I think it's going to be, I think there's a huge amount of exciting work to be done in this field, so we'll see what happens.
More for me. You suggested that by one interventions were less effective than behavioral
Yeah.
interventions. Is there any studies to show the combination of both approaches?
Not that I'm aware of. So the DPP randomised people to standard care, lifestyle, trobutazone or metformin, so they were side by side. I don't think any have randomised to additive, unless anyone in the audience knows otherwise. No. But you may not expect an additive effect, I guess. If your lifestyle is that effective, is an additional pharmacology going to do very much? The other criticism of the pharmacology is you're just lowering glucose. Of course you have less diabetes. Great. Thank you very much. And thank you to Shivani and John for fantastic talks. I think there's refreshment outside, Peter. Is that right? So please stay around, have a chat, and hopefully see you again.
Yeah. So just again, just a thank to the ADHI who put all this on, do a lot of work behind the scenes to get it all happening. And thank you very much to the speakers and for chairing it. Coffee's outside, and just remind you, next month there will be a session on respiratory disease.